Hello, everyone. Thanks for joining us today for our webinar in partnership with Women in Global Health on power and privilege in the medical profession. We have today a set of really wonderful panelists that will engage in the discussion through questions that we will direct directly to some of them. And this is by no means a formal thing. We will try to have a more like laid-back conversation and try to pass on some important points. And we would like you to all be engaged and ask any questions at any moment. You have next to the YouTube video, you have a chat box in which you can leave some comments or questions. And later on, after we have all the discussions and all the conversations, we will just catch each one of the questions and try to have the people here, the speakers, answer them. So first of all, I wanted to like provide a bit of background on why is it we're doing this webinar. Like since a few months ago, and when we started conversations with Women in Global Health, we felt that there was a need for our federation to acknowledge the still existing gender gaps that are mirrored from society in our organization. And we felt it was important to do it in a way that could reach out to as many members as possible. So this webinar is one of our like 3 interventions. You will hear more about the next ones in the next couple of weeks. And we're really excited to have this great like panel or set of speakers joining us today. And I wanted to thank you personally, Women in Global Health, for reaching out to all the people that will provide their knowledge and expertise on the topics that we want to talk about. Without further ado, I'm going to present briefly the people that will be speaking, and then we will start with the discussion and the questions. So the first one will be Desi. Desi is a medical doctor from Sweden, and she is like the gender specialist of Women in Global Health and also former SCORE director in the IFMSA. We're really happy to have you here. Thank you for coming back to IFMSA.
Thank you for being able to be invited to talk to you. It's really lovely.
Cool. Then we have Temitayo. She works at USAID and is the Health Workforce Technical Advisor in the Office of Population and Reproductive Health. Thank you as well for joining us. It's
happy to be here as well.
And the third one is Dr. Rosemary Morgan, who is an assistant scientist at Johns Hopkins Bloomberg School of Public Health. And she also works on the project research in gender and ethics. It's like the acronym reads RINGS. And she will provide us also some insight on the like power and privilege and why is it important to understand our own privilege later on during the discussion. And then we also have, oh, hi, sorry. Thank you for joining us. It's a pleasure. And then we also have Elise, a medical student from IFMSA and its immediate past president, IFMSA Australia. And we're also really happy to have someone that has been engaged in IFMSA providing their insight on this topic. And finally, like last but not least, we also have Kelly Thompson, like former LRA of the IFMSA and medical doctor, and also the gender advisor of Women in Global Health. Is that right?
All good. Thank you, Carlos.
Wonderful. Thank you for joining us. Kelly will be helping with the moderation. And now we will start a bit with the questions. Kelly selected some questions that we thought would be important to, as we said, explore and expose the different aspects that we want to cover. And I will start with a simple question to Desi on like whether you can perhaps introduce us to Women in Global Health and what it has uncovered about women's leadership in global health, and tell us more a bit of what you do on a daily basis there.
Can you hear me now?
Yes.
Okay, sorry about that. So I'm one of the co-founders of Women in Global Health. We're an organization that started almost 2 years ago now, which work with trying to make the global health world more equal. We the founders, four of us, are four women working with global health in different ways, and we all have a background of feeling that something's up within global health, as in many other spheres in the world as well. But we looked at the global health world, and we didn't see ourselves being represented there. We saw that even though the people working on the ground of global health, a majority are women, when we look at the leadership, a majority is men, and what's up there? So as you mentioned, I have a background within Scora, and I also have a background working with gender equality questions in Scora, but also in other organizations. So my background is that, well, I have been analyzing these questions before, and we've seen that there are many different reasons for gender inequality. But in order to do something about it, we need to work towards a better understanding of why it is this way, and also just showing people that something's going on. So we started Women in Global Health, working with advocacy and with also with talking about these things and teaching people about them, to try and make people understand, and understand why it's important, and understand why it's this way, and in that sense make it more gender equal. So one of the things we have been working on is looking at the numbers of what it looks like today. And there's a study that shows that around 75% of people working in global health are women. But if we look at the leadership, if we look, for example, at the World Health Assembly a couple of years ago, 23% of the chief delegates of the World Health Assembly were women, and today, last year, around 26% were women. So those are some of the figures we've looked at. We've also looked at other things, such as the World Health Organization's executive board, where 23 are men and 11 are women, which also is like a majority of men. Things are changing, but they're changing slowly, and that's something that's also, people are always looking to the younger generation for this. But if we look at IFMSA, for example, the majority of the leadership is also men, both when we look at the national presidents, but also if we look at the executive board in IFMSA, and that's something that me and the other people within my organization that have a background with IFMSA also have seen. So in order to change this, we have to work for gender equality, otherwise nothing's going to happen. And we want to be one of those voices working for gender equality. So that's part of the background.
Thank you so much, Desi, for this clear explanation. I think that you set up the basis really well. As a reminder to all the people watching, you can ask direct questions to each one of the speakers in the chat box next to the YouTube video. You can start dropping them now, so we don't have to wait for them all last minute. Thank you once again, Desi. I will now move with Elisa, and I will ask her a question about her specific context. She, as we said before, she's a medical student in Australia, and recently, looking at leadership and gender at different level, women's experience in medicine has recently received a lot of media attention in your country. Could you maybe highlight for us what has been happening?
Yeah, of course. So Australia is a really interesting case study in what happens when there is really rampant bullying and harassment in medicine, whether that's because of sexism or because of racism or because of any other reason. But also an interesting case study in what happens when that kind of harassment is uncovered and what people's reactions are going to be. So to give a bit of an Australian context for women in health leadership, we've got 50-50 when it comes to medical students, about half are women, maybe a little bit over. But when it comes to the highest levels of representation, about 1 in 3 of the heads of our medical schools are women. About 1 in 3 again for the head of our country in terms of the chief medical officers are women. We have about 1 in 3 specialists females, and only about 12% of hospitals with over 1,000 employees have female CEOs. So we've got what seems in the face of it a quite unequal situation. It's clear, the statistics aren't really disputed, but everything really came to a head in 2015 when a Sydney vascular surgeon made some fairly outrageous comments. It was received at the time, essentially saying that if people wanted to get ahead in surgery, then she would advise them to give in to any sexual advances that their seniors made. This ended up in the papers. It was an offhand comment that she made at a book launch, and it really changed the landscape of medicine Australia. The College of Surgeons had a very strong reaction to it. I think that everyone's first instinct was to pray that it wasn't true to the extent that it was being said it was true. But very quickly, the College of Surgeons undertook a huge review to go through the number of their trainees who are experiencing bullying. How is this preventing their progression up to leadership in different areas? So they got most of their trainees to respond to this survey. They found that 40% had experienced bullying, 18% discrimination, 19% workplace harassment, and 7% of that sexual harassment. So we came to a place where everyone had to acknowledge that this was pretty rampant. They can't uncover exactly what portion of that, of course, is sexism. Some of it is intersectional, some of it is racism, some of it is experienced by male trainees as well. But this really took off. This then culminated in a whole government inquiry, which is something very uncommon in Australia for the government to get involved in a specific area of medical practice. The government inquiry talked to all of our different medical regulatory bodies. In Australia, there are a huge amount of different organisations that interact in the representation and the oversight of the medical profession, and all of them were interviewed. We were interviewed as IFMSA as well to give our views on what was happening and why. It was a really great inquiry. I'll make sure that I forward through the link so when we advertise this, we can put it up, because it came back with a set of recommendations about how to deal with bullying harassment broadly, and that applies to, sexism and the whole range. I think that the most interesting thing that came out of this wasn't that there is sexism or there is bullying and harassment. I think we already knew that. We've seen that across the globe. I think the really interesting lesson was people's reaction to it. IFMSA, so the Australian Medical Students Association, put out its own survey around that time to see students' views on what was going on. And yes, we got a lot of responses from people sharing their experiences, but we also got some people responding with really antagonistic comments about how it was really important that we had bullying or that we had sexism, because those things make us tough doctors, and those things are just part of the medical profession, and if you don't like it, ship out. It's concerning that we still have those sorts of views in our generation coming up, but we can learn a lot from that. And we can learn a lot from what's happening globally, politically as well, when we see the rise of President Trump in the US, when we see Brexit in the UK. We're seeing these demonstrations of, mass revolt against what people view as political correctness, against what people view as, the progressive elites and their agenda. And that really applies here when we're talking about sexism, when we're talking about women and global health leadership, because there's a lot of people who, even when you show them these statistics that look really solid and really obvious, they kind of feel like there's something fishy going on. They kind of feel like they're being duped. They kind of feel like this is some strange progressive agenda that just doesn't quite fit with them. And so I think our takeaway from this has to be that we need to be able to bring people along with us when we are advocating for this cause. And that means that we can be very forthright, we can be very passionate, but we also can't beat people over the head with it. We've got to be able to explain to them why it is that it's a problem, that it's not, equal parity between men and women in global health leadership. We can't assume that they know that or they should know that, and if they don't, then they're ignorant. We've got to be willing to go right back to those basics and explain to people, and also to help them understand the benefits of having parity. If you can bring out statistics relevant to your own country, then that explain, for example, when we have more female CEOs here as a result, when we have more female policymakers, this is a result, and relate that to women in global health leadership. That can really help people understand. If you can show them that, there are economic benefits, there are benefits to an organisation, there are benefits to a health system, there are benefits to policy that reflects the needs of the whole population and not just one gender of that population, you can really get people on side. There'll always be some people who don't agree, but that would be my takeaway message, that if we can all really work at bringing people along with us, then we have more and more people willing to get alongside us and fight for the same thing.
Great, thank you so much, Elise. That was like extremely interesting. It's great to hear kind of the evolution of how a kind of an offhanded comment sparked all this inquiry in Australia. And also I think as medical doctors, medical students, really interesting to hear that like we have this culture that's so ingrained in us and we're told I had to do it, it's hard, it's difficult, but that we really should be questioning kind of why we're doing things and why things are how they are. But we know in this difficult kind of setting that it's not easy. You can't just walk up to somebody and say, this is wrong and we have to change it. But trying to kind of figure out ways of improving and trying to address the problems. And you've kind of hit on the idea of intersectionality, talking about racism in Australia. And I think that leads nicely into our next question, which is for Temi.
Before that, could I just add
Go ahead.
a small thing to what Lisa is saying? I also thought it was really interesting, and I want to just add something small to this, because there are these people that say, oh, but it's funny, we need to be able to use humor to when you're in medicine. We didn't mean it that way, it's just a joke, blah blah blah. And of course what you were talking about is not just a joke, but sometimes people use that as an argument. And there are studies that show if you use sexistic humor, your workplace is going to have be more sexist, and that's going to affect like both women and men. Men are going to have more in wage and so on. So just saying that it's humor is not a good argument to answer that with either. I just wanted to add that.
Thanks. I think that's like pretty relevant as well. Like Elise brought up the current political situation in the United States and with Brexit and this kind of revolt against what they call political correctness, but actually showing that there's evidence that we're not being politically correct, we're actually being progressive minded. So as I said, Elise mentioned about intersectionality, and Temi, I was just going to ask, we've had conversations before about intersectionality and global health and leadership. I'd just love to hear from you a bit more about if you could kind of give us a little brief on what intersectionality is, and then some discussion about your own experience and kind of barriers you faced in working and dealing with doctors and people in the medical profession.
Great. Thank you so much, Kelly. So the perspective that I'm bringing is one of someone who has worked as a hospital administrator and has been in hospital management, having to lead teams that have had doctors, nurses, and a number of clinical and non-clinical staff. It's also coming from the perspective of working at USAID, where we've supported a lot of leadership initiatives. So when we talk a little bit about intersectionality, it's the idea that people aren't just male or female, but that they have other identities. You think about things like which class they grew up in, what their ethnicity is, what their race is. And sometimes those identities come together in very unique ways, especially when it comes to dealing with systems of the way that oppression happens. And so whenever we talk about ism, or sexism, classism, we're talking about types of oppressions. We're talking about the ways in which people are treated differently based on their particular identities. And so normally what you see, especially when it comes to the area of health, you start to see not only in leadership, but in terms of how certain things come up in certain patient populations. So sometimes women have certain ailments, but Black women might experience things uniquely. And you oftentimes see that in terms of like chronic care. There have been a lot of different studies that have looked at intersectionality. And so when you look at things that look across populations or people by different areas, like their age and their gender, or their gender and their ethnicity, or their gender and their neighborhood, you're starting to try to analyze and get to the ways that, because your different identities work with each other, that you experience things in a unique way. So intersectionality, and the way that I've always seen it and approached it, means that my experience and my interaction and the way that people react to me, especially in healthcare, has been interesting. So because I am a young Black woman in a position of leadership, so because I've always done hospital management, people have responded to me in very specific and unique ways. Oftentimes as a hospital manager, you're in a position of decision-making power. You have to work with physicians who are oftentimes, and rightfully so because of the training, our whole enterprise depends on their knowledge. So we've always historically have had a very high level of respect, and physicians have oftentimes been the leaders in the hospitals where I've worked. They've been the leaders of the health systems where I've worked. They tend to be the heads of state. They tend to be your ministers of health. They tend to hold the highest roles. And so when you have someone that comes along that doesn't conform with that, it's a challenge for a lot of people. It's a challenge for people to say, why should I listen to you? Or the types of questions that they ask. You know, they often say, well, are you trained to do this? How do you know what you're talking about? And so the way that intersectionality has played out in my life and in my career has been this additional level of questions. People seem to want to know whether or not I'm qualified for the opinion or whether or not I have the experience I have. And I think, as I said, it's not just the virtue of me being one thing, but it's a virtue of me being all of these things, a young Black female working within a particular culture that where I'm an ethnic minority. And so I think, you know, in terms of my thoughts moving forward for medicine and the importance of leadership, I think that there's a huge role that organizations have and they play in terms of looking at their data. One of the big things that came out recently here in the United States was the issue of consistent pay gaps between female doctors and male doctors. And a lot of people couldn't believe that still in 2016, which is when the report came out, that we're seeing things like a $20,000 gap for people who get the same training, have to go through the same rigor, and even once they've reached that they've graduated and are working, are consistently being paid less. And so this has been a call for accountability for organizations on a large scale to really think critically about how they are perpetuating gender differences. So I'll stop there, and thank you.
Thank you so much, Semi, for your intervention. I think it was really important that we brought intersectionality on the table, and it was really enlightening from you to actually explain specific situations and how people reacted towards your situation. I also wanted to ask a further question to Rosemary, which is kind of related to what we've been talking about, and it's kind of like the convergence of the things that the three other speakers have mentioned. So we have explored several different areas of medicine and health leadership, and we see that the common thread there is that it's related to all these topics are related to power and privilege, and there's always the disparity between individuals. Why is it important? Why do you think it's important to actually understand our own privilege? And how do you feel that this privilege manifests within institutions and the different entities in which we work?
Yes. So yeah. Great questions. I just want to let everyone know kind of where I'm coming from as well. It was mentioned that I'm based at the Johns Hopkins Bloomberg School of Public Health, and the main project that I'm working on is called Research in Gender and Ethics, Building Stronger Health Systems. And our main goal is to galvanize gender analysis within health systems research. And part of that, get individuals within our, individual health system researchers to think about how power and privilege manifests within the institutions, processes, structures, practices in which we work. So what I'm going to be talking about today comes really out of that work that we have done looking at health systems researchers and the work that is done, and the power and privilege that manifests within our own institutions. So why is it important to understand our own privilege? Well, firstly, it's about recognizing that inequities exist within the institutions in which we work, and that social identity can actually be an asset, contributing to success as surely as personality, skill, or experience. And by social identity, I mean our gender, our class, our race, whether we have a disability or not, or whether we're able-bodied. It's important because understanding our own privilege enables us to use it to reduce these inequities that exist and create or attempt to create a level playing field within the institutions and structures in which we work, really with the ultimate goal of creating a more inclusive and representative environment. One thing that's important right here is that recognizing our own privilege can be an uncomfortable process, and we often get a lot of pushback when we talk about these issues, especially because privilege by its nature is often unearned and unjustified. So some of us have privilege may not actually recognize it at first. Instead, we accept our privileges unconsciously, viewing our own experience as the norm or solely the result of our hard work and the effort that we put in. But once we understand how privilege works, those in positions of privilege may feel guilt and thus get defensive. So often when we talk about these issues, people do get quite defensive. It's important to understand that it is not about you directly. You know, it can feel like you're being called sexist or racist, or you automatically want to say, well, I'm not sexist and I'm not racist. But I mean, this is not the point. It's about recognizing that sexism and racism exist within our institutions in which we live and work, and understand where we fit into this and how we can respond accordingly. And that giving more power to others does not take away from our own. And on the flip side, for groups that have been historically underrepresented in the field, an awareness of the effects of socially conferred privilege, and with it the knowledge that their experiences are likely not unique to them or caused by them, can actually be very helpful. So how does this privilege manifest within the institutions in which we work? Well, you've heard some great examples today from some of the previous speakers. So the way that it manifests can influence who gets hired, who gets promoted, who gets access to training and other opportunities. For example, in terms of hiring, there's been lots of studies to show that people with ethnic sounding names are much less likely to even be offered interviews, job. Within the institutions themselves, as Desi had mentioned, there are much fewer women in top leadership positions. One study showed that in the US, for example, only 11% of department chairs in medicine were women. And another study showed that 24% of directors of global health centers in the top 50 US medical schools are women. Interestingly, a way that this plays out is when we look at the nursing profession, which is a much more female-dominant sector. What we see is men do in this field, they are much more likely to advance and enter leadership roles. And another example is that women and minorities are often asked to sit on committees to ensure that the committees are seen as more representative and diverse, which actually takes them away from other activities which are more lead to promotion. And then when they do say no, there's much more negative repercussions compared to men, because women are often supposed to be seen as non-argumentative, supposed to be seen as nice. There's many examples of how power and privilege manifests in institutions, but these are just some of them. Thank you.
Wonderful. Thank you so much for this great insight. I wanted to ask the other speakers before moving on to the next round of questions, if they have anything to add. We've talked about how these power relations create, unfortunately, really negative consequences, like tokenism, patronizing attitudes, and stereotyping. And when we dig deeper into the medical profession, we see women having lower wages or less chances of accessing residency spots. So how do you want to reflect, if you have anything else to add, how do you want to reflect on what has been said so far by the speakers?
So this is Temi here. I just want to say, going to what Rosemary was talking about and having been someone who's been asked to be on certain committees, especially ones that are targeted at diversity, I think there's a number of different ways in which you have to have meaningful engagement. I think that the intent oftentimes by making sure that you have representation is a good one, but I think sometimes there's not room or space for meaningful engagement. And so there are simple things that have been in the structure of meetings, like allowing those who normally wouldn't get to speak first, or making sure that it's everyone's responsibility, just not women, to fix gender gaps. This is actually a collective effort. And so I think oftentimes we put the responsibility on those who are disadvantaged or feeling the oppression the most to fix the problem. And oftentimes what we realize is women can't be the ones trying to fight for women's issues. There also has to be an acknowledgement on the other side. And this gets to a little bit of what Rosemary was talking about, in which sometimes those who are in the beneficial position, who are benefiting from the situation, or oftentimes in positions of privilege, to also be part of the conversation.
That's also something that we talk a lot about in Women in Global Health. Sorry. That people in power positions, regardless of gender or any other thing, need to take their responsibility and act in a transformative way, so that people of all genders get to reach higher positions and get to go further in their careers. Because it's not just women's responsibility, or it's everyone's responsibility. And if we want to reach, as Elise was saying, in order to reach a more equal or a better global health status of the world, we need to include everyone in that work, not just one gender.
Wonderful. Thank you for adding your interventions to what has already been said, which so far has been amazing. I wanted to ask if there's anything else that any one of you want to add, and if not, we will move on to the second round of questions, which is that now that we have set the basis, that we have explored the problem from a basis perspective. We're going to talk more about the role of young medical students and the role of ourselves, on how can we better understand our privilege, and how can we address and tackle these issues. So my next question will be directed to Temi. And it's basically if you have any advice for young medical students and people interested in global health on how they can work to address inequalities in their work.
Absolutely, thanks. I think the number one way is that there's no one way of practicing medicine. One of the fascinating things that I've started noticing as I've studied and worked across a number of different health systems is that the beauty of kind of being in medicine and being a medical student and kind of pursuing medicine as a career is that you get to practice it in a lot of different ways. I've got to interact with medical doctors who've started their own organizations. I've got to work with medical doctors who went into data. I've worked with physicians who dedicated themselves completely to clinical care. But the beauty of it is that it can be what you want it to be, especially in global health. There's a lot of flexibility. And the biggest thing is that the strongest point is that medicine works within a health system. So those doctors who get out there and are able to do more are those who've been able to recognize that you can't just practice and heal your way out of a system where you don't have running water. Or that if you're going to stay in your home community, that there's a number of different ways that you can collaborate with patient groups and make your office and your services more friendly than just kind of what the clinical and academic environment dictates. So the number one thing that I would say is that there are many ways to practice medicine. And that one of the things that's hard is because it's of the mentor and the model in which medical students are trained, it's sometimes hard to feel like you can change those systems. They feel really big, they feel really old, and they feel very much as though those behaviors are hardwired and that you can't change them. And from what I've seen is actually you can start small. You can start within your department. You can start with lunch. You can start with small areas of kind of building leadership around you. You can bring ideas up. You can bring ideas forward. You can choose perhaps to not practice medicine or practice medicine part-time. One of the two practices that are doing things really, really exciting things is there's a guy named ZDoggMD. He makes lots of YouTube videos, and he talks a lot about how he's been able to use medicine and Star Wars to really get a lot of attention to the struggles that physicians feel. And he's become a spokesperson for bringing creativity to and really starting some hard dialogues about how insurance works and reimbursement and working hours. And so what I would say to medical students is, medicine is not always clinical training, practicing is not always going to be what makes everyone happy, but there's a lot of different ways, especially in global health, that you can practice medicine. So look for that and look for people who are doing cool things with their medical degrees and talk to them.
Great, thank you, Tammy. I think that echoes back to some of our earlier conversations too about, the system that we're working in and how to recognize what that system is like and to not be afraid to be different. And kind of, I think that what you've said and your suggestions really talk well to IFMSA or people involved in IFMSA, because tend to be people who view medicine less in the kind of traditional clinical sense and try and have a broader approach to it. And I think that's some really great suggestions about how to start to kind of unpack and break down what we're talking about here, and how kind of in your everyday life can implement it and kind of in your working life. And then like kind of building on that, I'm going to pose a question to Rosemary. I'm just kind of giving us some more tools and talking about how we can better understand our own privilege, and then how we can use our positions of privilege to reduce inequities within our institutions.
Great. Yeah, thanks. Well, first, I would echo really everything that's been said already. And, it is really important to understand our own privilege. And there are some kind of tools and different things that you can use and ideas you can engage with to begin to start to understand what this looks like. Peggy McIntosh most famously unpacked what she called an invisible knapsack of privileges socially conferred upon whites, men, and heterosexuals, and the tool used your own privilege. And actually here at Johns Hopkins, right after the election happened, there was a lot of anger and upset amongst the student population. So the students doing a master's in public health, a lot of the students who are from minority backgrounds, who are from, or who even American are from other countries, they were really upset about what was happening, and they went to a talk at Hopkins, and they really didn't feel like their voice was being heard. So what they did is they used this tool that Peggy McIntosh created called the Invisible Knapsack, and they adapted it for our setting, our public health school setting, and created a list of questions for faculty and other staff members to use to start thinking about this. And this is something that you can do as well. When first understanding this concept, it really helps to think about privilege in relation to single identity categories, such as able-bodiedness, maleness, or whiteness. However, I want to reiterate what Tammy said about intersectionality. It is important to recognize that social identities do interact, that sex, for example, intersects with race and class and disability and sexuality, etc., to create different experiences of power and privilege, disadvantage, marginalization, oppression, for example. So whereas a white woman might experience sexism, a Black woman may experience sexism and racism. And this concept also helps us to understand why a person can inhabit positions of privilege and disadvantage at the same time and depending on the same situation. So in some situations where I have privilege, other situations I might not have privilege. And it's really important to understand that. And all individuals can experience both power and privilege and disadvantage at different instances. So going back to thinking about privilege in relation to a single identity category, it helps to try to understand some of the privileges a male doctor may experience over a female doctor, for example. So is to have his expertise questioned or his authority challenged by patients or colleagues. And Temi mentioned her own experiences in relation to this. Colleagues and patients will assume that he was hired because of his merit, not because of affirmative action, for example. He is not going to be asked to sit on panels or committees to make them more diverse, which will take away time to do other work. And also work schedules around healthcare duties. People will admire him for his priorities. Alternatively, if he works around the clock and he is unlikely to be judged negatively for putting his family second. If he is passionate about an issue, he is not going to be judged as being emotional or rational, dressing for work and seriously, and will never have to consider whether his work clothing may be perceived as sexy or frivolous. And lastly, he will naturally and expect to be paid a competitive salary. And these are just some privileges that male doctors may experience. Some may not. But it's helpful to think of it in these terms to begin to start to think of things that were just natural to you and in your daily life, that actually they are privileges and that not all people will have access to these things. So, I think the second question was, how can we use our position of privilege to reduce inequities within our institutions? And what I want to talk about is thinking about how we can reduce inequities as medical students, but also, as you're and you do gain more higher level positions, how you can start thinking about these issues. Well, firstly, it's important for those who enjoy social privileges to recognize the nature of such privilege, like just everything we've been talking about today, understand how privilege shows up and how we might actually be unknowingly perpetuating it. Privilege allows us to speak up and have an opinion without putting our jobs at risk, whereas people in less privileged positions won't be able to speak up as readily. That, as a result, we can leverage our position to amplify the voices of others. For example, when you're in a meeting and a female colleague makes a point, sometimes the point will be overlooked and there's a lot to suggest that this happens. And then when a male colleague will jump in later, make the same point, and he'll receive the credit. If you see something like that happening, you step up and you say something and you make sure the person who deserves the credit gets the credit. We need to challenge and question practices, policies, procedures which perpetuate inequities, and awareness of these issues can therefore inform our policies for hiring, retention, promotion of diverse colleagues. And lastly, we can become not only more informed colleagues and friends, but also more supportive mentors to those who face different challenges working in the environment in which we work. Because, not everyone's going to have the same experience as us, and we need to treat other people's experiences as valid. That just because it's not something that's happened to us doesn't mean it's not happening. And we need to recognize this and towards reducing these inequities whenever possible. Thank you.
Thank you so much, Rosemary. It's difficult to encapsulate all these thoughts and all these conversations, but I'm really glad that you brought in like some clear examples of how privilege works, and also on intersectionality. I think it's going to be really useful for the participants and the viewers that are watching currently. I I wanted to move on to the next question, but we will have more room and more time later on to discuss on all the small things that have been mentioned during this conversation. And like the next question is directed towards Desi. So Desi, as a former IFMSA SCORE director and co-founder of Women in Global Health, advice for our participants on how they can address what we have discussed today in their own medical associations. So actually how to bring all the knowledge that has been shared today by our wonderful speakers to the ground and actually like make some change in their communities and in their organizations.
Thank you. I want to add to what Tammy and Rosemary already said. They were talking about really understanding your own privilege. And as medical students or medical doctors, we all have a lot of privilege, as you understand. So just being in that position makes you, it means that you're able to do a lot and that people actually listen to you. Even if it doesn't always feel that way at the hospital, people do. So I think we need to keep that in mind and also explore our own privilege, not use it, but like be aware of it in all senses. Because it's kind of easy to forget that you're able-bodied, and if you're living in a country where people have quite a good lifestyle, that you have a good lifestyle, or that you're white or whatever you are. And we need to be aware of that in order to actually change things for people, for everyone in the world, in order to make it more equal. So again, be aware of your own privilege and use your power position to change it. This is what I usually say to people. Many people don't have a good mentor out there or a good leader that they can look up to, but become that leader. So if you haven't had a person around you in a leadership position that have made sure that women and men and other genders are equally treated and have the same opportunities to actually go all the way. Make sure that when you're in that position, listen to everyone and try to remove your biases against gender or against sexuality or ethnicity or whatever. Because I also think that's what in the end is going to change the world. And that's also, and I wanted to add that, a reason why we're talking to IFMSA, because you're the people that many of you are gonna become global health leaders, and you need this capabilities and knowledge to do some change in the future. We're leaning to you. So that's one thing, educate yourself. But also, and this is maybe thinking more about what you can do today, is use IFMSA as a tool. Learn as much as you possibly can while you're in IFMSA, and learn more about gender and intersectionality, because that's you might not have the time to do it later, and it's good to know it already now. And also use IFMSA as a platform for advocacy, which I know a lot of you already do. So by using IFMSA, you have a big voice behind you and saying that, okay, we need to actually look at the gender equality or in other intersectional questions as well in, for example, WHO, and they're questioning what the fuck they're doing, because they're not always doing it right, as we know. So that's something that I also think we can do. And another thing, which you're already doing right now, is working with IFMSA in itself, which obviously isn't gender equal in any way. We can make it a lot better by using the bylaws of IFMSA itself and make sure that we actually make it more of a democratic organization than what it is today. And practice using those things. I think that's an excellent opportunity to do that. And another way, and which a lot of you in SCORE at least are doing already, is working with sexuality education. And a big part of sexuality education is working with gender equality and questioning the gender norms in each country, because I know it looks very different depending on where you are. And another thing, I can go on and on for ages, but always put on your intersectional glasses or gender glasses. I question people when, like, if you have a lecture that says something sexistic, for example, and I think this is something that happens everywhere. So the mom takes the kid to the doctor, and you can be like, or the dad. There are dads as well that take care of their kids, and be that voice, so that people are aware that, okay, it doesn't have to be the mom that always take care of the kid in a heterosexual relationship. It could be two dads, or a single dad, or a single mom, you don't know, but just question the ways that you always look at it, because if you don't, there's a risk that no one will, and that no one will think about it being in other ways as well. And that's just sad, because it makes us more single-minded, and it makes us also worse doctors in the end. I think I went out on a tangent there, but I still think that all these things are relevant for us as future leaders in medicine, future doctors, and future leaders in global health. I was going to say something else, but I don't remember it right now.
Thank you so much, Desi. If you remember what you were going to say, you can always pop up during the questions, the Q&A time, and you can always say it. I will leave the floor to Elise now to see if she can answer a question. So basically, the question is that you have already given us a great overview of what happens when a health system starts to evaluate itself. But do you have any advice for medical students seeing similar things in their own hospitals, and how can they bring them to light and actually expose them?
Yeah, sure. I'll keep it brief because I know we're coming up to time. I would think about that in three ways. I would think about, what do you have as an individual, as a community, and as a policy environment? So as an individual, if you are faced with experiencing bullying because of your gender, or if you've missed out on a job because of your gender, or because you're pregnant, or because something related to your gender, what is your individual capacity to do something about it? For example, do you know what pathways to take to go and deal with that when it happens? In terms of a community response, what is overall the culture of your hospital and the culture of your health system? Is that the sort of thing that other people who are bystanders are going to allow? Is that the sort of thing they're going to step in? And then look at your policy environment. Are there laws that protect, for example, gender equity? Are there laws in your country that protect the right of people not to be discriminated against during pregnancy, or because of their gender, or because of any other kind of asset of their identity? And once you've mapped out those three things, you can get a feeling for where to go forward. Our example in Australia gave us a pretty firm way to go forward, because we didn't have a lot of individual capacity, in that most medical students or doctors didn't feel like they could stand up and make it stop if there was some kind of, sexism or bullying incident. But we did have, some kind of community backing, in that there were a number of people in the health system who were willing to be strong voices, and there was definitely a public groundswell within the general community in Australia who wanted change. In terms of our policy environment, there's legislature that says that you just can't do that. You can't treat people differently because they're men and women. So if you can assess your environment in terms of those three things, and then go forward with whatever your strength is. If you don't have legal protections, or if you don't have a particularly strong individual capacity to speak up about what's happening, but you know that there are some strong voices in your health system, that's your community response, then seek them out and try to work to amplify their voice. When you're a medical student or a junior doctor in particular, you're very vulnerable. If you are someone who tries to take on the health system all on your own, especially if you're talking about something that happened to you rather than advocating on behalf of other people, there's potential that's going to impact on your career, and that's going to impact on how people see you. And it may also impact on how seriously and legitimately people take your claims. So always try to find people who are more senior and who are therefore more protected and more stable, who are going to be able to back up your claims, and who are going to be able to, contribute a driving force to that advocacy. And if you can find really diverse people to get involved with your cause, then more the better. If you can find people who are, not the typical subject. So for example, if you find a surgeon who's willing to back you up, if you find a male doctor who's willing to back you up, that gives your voice more power, because that then reaches a whole different group of people who are more willing to listen to you and are less likely then to just dismiss it as that's just a student issue or a junior issue or just a women's issue, because you're bringing in more legitimacy with a wider range of voices. Does that answer the question?
Please. I think it answered the question awesomely, and thank you so much for your answer. I wanted to say that for the sake of timing, we're gonna move on to the Q&A now. And we have actually quite a few interesting questions from our viewers. But before moving on to that, I wanted to thank you all for being here and for providing your expertise and your knowledge in such a great and actually comprehensive way for all the viewers to understand how can we face gender disparities, how does it actually work, and how can we tackle it from the core. I'm going to move on to the questions. There are some questions that are directly aimed at particular speakers, but there are some that are open. So I would say that we can give between 10 and 15 minutes to answer the 4 most interesting questions, just for the sake of timing once again. And for the ones that are not aimed at a particular person, the first one that pops up and has an answer, may as well be the one answering that, and then it can be complemented by other speakers. Does that sound good to you all?
Yes.
Sure thing.
Wonderful. So the first question is for Desi. So this question is from Pepe from Spain. He says, "Hello, Desi. Thank you so much for the introduction. Many times when we address this issue, we get the answer that women have the same opportunities. There's not a real problem. How can we actually counteract this argument? Thank you."
That's an excellent question, and it's sometimes it's hard to do, but you can look at it on several levels. I think I sometimes use this instrument to look at it. I look at so are there financial inequalities in the country or in medicine? And yes, there are. Women get paid less. And then you can look at the structural barriers, which can be that, for example, it might be harder for women to get to work because they're at risk of being sexually harassed on the way, or legal things that make it different for men and women. You can also look at the social barriers, which I will get into more in a moment. Then there's also we have different bodies, so women get pregnant, which could also sometimes be a barrier because you can get pregnant when you don't want to, or just being pregnant is a risk and sometimes hard to work when you're pregnant as well, which makes it not the same for men and women. And then there's the psychological part, and at how it is today, women and men do have different on a group level psyches, and it's partly because of the social differences between men and women. We get treated differently from the first seconds that a baby's outside the womb, which also makes it, if you're always treated in a different way, you're gonna start acting in different ways. And adding to the social differences, and this is something that I usually bring up when I have this discussion with people, because it's something that people again and again ask you about. No, there's no differences, but there are. Everyone has a gender bias, and people that think they don't have a gender bias, studies show that they're actually more, they tend to treat men and women differently in a higher grade than people that are aware that they have a gender bias. There's this study made, I think, on Harvard students that where half of the group gets to read a discussion about a leader that's called Joe, and the other half of the group gets to read the same thing, but where the leader is called Joanna. And everyone says that as a leader, they're both capable, but they tend to like Joe, even though the texts are exactly the same, but they don't like Joanna. this just proves that we all have, or not all, but we have a gender bias, and we're gonna treat people differently depending on their gender. And I think it's good to have some of these when you have these discussions, to remember some of these studies and remember some of, like, actually show people, even though you think you treat women and men the same, you don't, because no one does. And we need to be aware of this in order to actually change these structures. We have different, we have different ideas of what men are going to do and what women are going to do. And if women break these norms, they're going to be treated in a different way than men if they're doing the same. For example, I'm going to give you another example, and then I'm going to stop talking, okay? If a man goes around with a baby stroller, everyone thinks, at least here in Sweden, that, oh, that's such a good dad. Whereas if a woman goes around with a baby stroller and she looks at her mobile or something, they're going to think, oh, she's not taking care of her baby. And men just having a baby stroller, even if they look at their mobile, they're going to be like, oh, such great parenting. And this is also one of those things where we look at men and women differently. I hope this answered your question. I'd be happy if you want to discuss it even more, because this is something that I really think is very interesting.
Indeed, Desi, thank you so much for such a comprehensive answer. I think it's like you were mentioning, it's really important to understand that we are all somehow biased, and that comes from a clearly biased society, and it's good that we get to recognize that and fight against it. And based on that, I want to link this your answer to the next question. We were talking earlier on about like privilege, and how we need to also like acknowledge our own privilege and use our own privilege to fight against inequalities. Is from Gabriela, and she's asking, how can we use our own privilege to propitiate change without feeling ashamed of it? I want to maybe direct this question to Dr. Rosemary, and looking forward to your answer if you feel like you can answer to that question. Thank you so much.
Yeah, you're welcome. That's a great question. And it's something that comes up, I guess, a lot in the people that when you come from a position of privilege, and we all have some privilege on, one level or another, and attempting to enter a space that is not about us directly. It's, for example, if here in Baltimore, where I'm based, there's been a lot of discussions around race and racism and inequality. And I was talk the other day that looked at how we can navigate our own whiteness and the privilege that comes from that to help a community, like a community that doesn't have the same level of privileges as us. And there was a lot of discussion around guilt, coming, because privilege is unearned, it's unjustified. I've got this privilege by the nature of my birth, of where I was born, the country I was born into, the family. And, it can warrant levels of guilt. And I think that kind of where question really comes at, how can we not feel sort of ashamed, or I think it's about making sure that through our work, whether that's amplifying the voices of others, drawing attention to inequities that exist, speaking up when others can't, it's making sure you're not making that it all about us in that sense, that we're not taking over the conversation. I think Temi talked a lot about how, talk some about how individuals are asked to sit on committees, and this is a common thing in academia. Women are asked to sit on committees, minority women, especially in fields that are typically male dominated, because they want to be seen as to have diversity. And as a result, women and minority women end up on way, way more committees than men do. But Tammy asked the question, are they really engaging in real dialogue? And often we're asking people in these positions to come up with the answers and to respond to the inequities. And that's not fair, one, but the nature of us having privilege and a level of power, we can enter those spaces, but we need to work with those groups and create dialogue and meaningful conversation with those groups. Sorry, a fire alarm just distracted me in my building. I don't know if you heard that, but yeah, so I think that's really, we're gonna have feelings of guilt, and I sometimes have it. We're gonna sometimes feel shame that's not warranted. A lot of it isn't warranted. And when people are having these conversations, what you ask, are they talking about me? Do I hear myself and what is being said? And no, often not, but but maybe you do, because you could just come recognizing these issues now. But if not, then recognize it's not about me, and respond accordingly. And that these feelings are going to exist and they're valid feelings to have, but we just need to kind of work through them. Thanks.
Thank you so much for your answer, Rosemary. I hope that the person that asked this question cleared the doubts out. And if you have any other questions, feel free to leave them on the box, and we will get back to them after the webinar and find a way to reply to them. I will move on to the last question that I will pick from the Q&A box. This question is from, it's actually from two people, from Carlos from Colombia and Idil from Turkey. The question is, what's the stake of transgender individuals and people that identify with non-binary gender identities in regards to the gender inequality vision? And since the two last questions were aimed at Desi and Rosemary, I was wondering if maybe Tammy, you would like to answer this question. Or what's the role? How can we engage, or how can we include transgender individuals and individuals that don't identify with the binary system into the gender equity response?
Absolutely. Thank you. One of the things that Desi talked about earlier was trying to figure out ways in which you can be gender transformative. And I think that that's a principle and a concept that applies to a number of different areas. So you're not just talking about how do we take one's gender one's gender into account, but really how do we start thinking about the way that we work, the way that we treat individuals differently, and then try to change the systems around it. I think when it comes to looking at transgender individuals, especially around those people who do not identify, I think there's a couple of different things. One is looking at the way that oppression works, and based on transgender identity, there's a number of different things that kind of put transgender individuals in different cultures at higher risk for different things. From a patient side, you oftentimes find that physicians are not able to deal with transgender patients, that the services are not structured in a way that the questions that we ask make certain assumptions about people's behaviors, and that there isn't really a lot of thinking. Everything is very binary, black or white, male or female, that sort of thing. And when it comes to the training of physicians who they themselves identify as transgender, I think that for those who identify transgender male, not replicating the same oppressions against those who are women. And I think that that's a way in which, when we think about trying to be transformative, it's really trying to make sure that the oppressions that people experience, both as providers as well as those who are recipients of care, that we really work hard to take into account what positions of power or disempowered that they've been put in. I think that in terms of the international arena, there's a huge problem that's where we don't oftentimes talk about transgender issues. I think right now, a lot of the discussion is focused on the difference between males and females, self-identified males, born males. But I think that there's opportunity and room and definitely to increase and have a much broader discussion about how do we talk about difference. How do we talk about difference in medicine? How do we talk about difference in practice? How do we talk about difference in the way that we deliver care as well as treat people who do not conform to certain ideas? So that's some of my initial thinking. But I completely hear, and I'm really glad they raised this question.
Wonderful. Thank you so much for your answer, and thank you so much once again to all the speakers. I think this was really nice, and we have a few other questions, but like I mentioned, for those watching, we will get back to you with the responses. I just wanted to ask you whether you can just write them as comments on the YouTube video, because once the live stream is over, the question box will go away, and we don't want to lose those questions. And after that, they will be sent to the speakers so they can provide their input. Just to wrap up this great webinar, I wanted to go back to each one of our panelists and see if they can provide some kind of closure statement or like a final thought or take-home message. I think that would be a really nice way to finish this. We can start with Desi. I see that she wants to talk a bit.
Yeah. So one thing that I want to recommend everyone to do is to use your gender glasses and intersectionality glasses. And one thing that you can do now is just look at this panel here. How privileged are we? If you look at this, where the countries represented are the United States of America, Australia, Sweden, and Spain, which is also just being aware of this is a way to move forward your gender analysis. And this happens not only here, it happens everywhere, but I think it's something that we need to talk about and need to move forward with. So, and this is something I've been participating in organizing this, so it's on me as well. I just wanted you to be aware of it and see it. So that's one thing. And check your own privilege, as we've been coming back to over and over again. And I also want to say again, to when you become leaders in the future or now, which many of you are already global health leaders within IFMSA, try and be as gender transformative, like changing the actual gender inequality in your organizations as much as you can, because we all have a responsibility of changing the world we're living in. Thank you. And thank you all for joining. It's been lovely talking to you and all the panelists as well.
Carlos, you're on mute.
Sorry for that. So maybe, Temi, you would like to give us a take-home message?
Yep. So part of what I would like to say is, as we kind of move forward, we do have room as leaders to open the doors. I think that that's one of the biggest things that I've noticed is, as I've been in positions of power, to make sure that with my behavior that I'm creating opportunities for others who otherwise would not have a seat at the table. So I think that even if you do have privilege, being able to recognize that you're in a position to do something differently, that's been my take-home message. There is no one way to be a leader, and you can use that leader responsibly and that leadership position responsibly. So, one of the big things that I always say is, by virtue of you being there means that you can change the conversation, you can change the direction. So being able to just say and look for opportunities to engage people who ordinarily you would not engage, and be able to create seats at the table and engage people who are historically disempowered. So thank you.
Thank you so much, Temi. And Rosemary, what's your closure to this webinar? Thank you so much.
Yeah, well, I've been speaking a lot today about, recognizing one's own power and privilege, and that's kind of step one. And by the nature of you being here in this webinar, already moving in the right direction of making a change, making a difference, and just really realizing that for those of us that are in positions of privilege and power, that giving power to others does not take away our own, and that these are challenging things, concepts to deal with, and issues to deal with, and it is a long process, a long road. Change doesn't happen overnight. It's going to be baby steps, but as you move on in your careers, to keep all of this in mind. And the diverse teams, studies show the more that diverse teams are, the better they are, the better they do, the more they outperform, and the more diverse and inclusive we can make our environments, the better off everyone's going to be. And right now I'm US, so there's been a lot of talk about politics here lately. I'm actually from Canada, so we have another high income country represented here. And it's not about building a wall, it's about building a longer table. That's the thing that we've been hearing a lot here, especially a lot of Canadians saying, and I would reiterate that here. It's in our own institutions, not just in our countries. So build a longer table. That's what would be my take home message. Thanks.
Great take-home message. I hope that we can pass that on to Mr. Donald Trump at some point. I wanted to give the floor to Kelly now for also a final message from her side. Kelly.
Great, thanks, Carlos. I think everybody has brought up some really amazing points. This has been a really interesting webinar, so thank you guys so much. And I think I just kind of want to re-emphasize that you've kind of been given a lot of knowledge today and some tools and some ideas like unpacking the backpack and unpacking your own privilege. And I think that's just a really great way to start, is just doing really simple things, about thinking about yourself and what you have access to. Even talking about the webinar, Desi pointed out that we have a lot of white women from the global north on this panel, recognizing our what we've done ourselves, but also recognizing in yourself what you have, and thinking about on the webinar we're also using internet, and that we have good internet, and that there are people in IFMSA who might not be able to access the internet to see this webinar, and bringing what you've learned here to kind of your work in IFMSA at in your own meetings, just sitting back and thinking, okay, am I talking too much? Listening and looking at who's talking. The IFMSA GA is coming up in March. That's a really good opportunity in the plenary to think about who's proposing policies, whose voice is being heard in the discussions, in the president's sessions, who's talking the most, who is kind of pushing their ideas, who's doing the most politicking, and why are other people's voices being left behind, whether it's the voice of women medical students, or if it's the voice of medical students from the African region or EMR or different regions, and why are those people being left behind, and what IFMSA can do to kind of improve access for these people and for their voices, and even looking at who's not in the room, and looking at different regional meetings if you're on the team of officials, and seeing, okay, why does this region have 300 people in it, and this region only has 10 people in their meeting, and thinking about what's happening and how you can kind of try and address things at a very simple level. So that's all I have to say. Thank you so much, Carlos, and to everybody, and to IFMSA for letting us do this.
Thank you, Kelly. It's also been a pleasure for me being able to host this together with Women in Global Health. As I mentioned, this is the first part of some interventions that we have planned. One of the next one being one that's going to happen in the March meeting in the form of a small workshop. So for all of those who are watching and are coming to our General Assembly, it would be really good to also have you there to keep discussing on these important topics. As a wrap up, I wanted to thank once again the speakers. these wonderful gender advocates that we've had here today with us, and that have brought light into such important topics that we need to definitely try to pursue a bit more in our federation. And also to thank Women in Global Health for getting in touch with them and for providing us with their time and their knowledge. As sort of my take-home message, I will make it mostly focused on IFMSA. We need to keep working on making this problem visible. We need to keep acknowledging that our behaviors and the way that we plan things are normally a reflection of society, and society, like we were saying, is gender biased and also holds a lot of different disparities. And I think that by exposing the problem, we're all doing already a good thing and setting the ground to move forward, and hopefully at some point achieving complete gender equality in IFMSA, which would be probably like a difficult to reach goal, but not impossible. And that's all from my side. I'm gonna go offline right now. All of you who are watching, you can spread this webinar. You can spread the link to your fellow medical students, to your colleagues, or to the people working for your national member organization, and maybe somehow this can change the mind of some people and bring some light on how we behave and how we still perceive things. So that's all for now. As if you remember properly, I asked you to put your comments in the question boxes in the YouTube link, and we will address them in the next couple of days, hopefully with input from our wonderful speakers. Thank you so much.